Hello everyone, my name is Kevin Chilbert. I am the PGY2 Emergency Medicine Pharmacy resident. This will be a lecture on vasopressors entitled Controlling the Resistance. I'd really like to focus this lecture on the specific types of vasopressors, their mechanism of action, the disease states in which they are warranted, and then proper titration of these medications. The objectives for this lecture will be to understand the different types of shock, recognize differences between multiple different vasopressors, develop a strategy for managing patients on a vasopressor. First, we have to discuss shock. There are 4 different types of shock: hypovolemic, cardiogenic, obstructive, distributive, and then distributive does further stratify into septic, anaphylactic, and neurogenic, each one of them presenting in a similar fashion, though the treatments may be vastly different. Over here on the right, we can see an image of the end-stage symptoms of shock, including severe hypotension, cold clammy skin, edema, somnolence and coma, oliguria, dyspnea, and GI bleeding and paralytic ileus. Now, each one of these different symptoms are signs of end organ failure that we are looking for that determines whether or not a patient is experiencing shock or if they are not experiencing shock. Now, we use these findings to not only diagnose shock, but to see the reversal of these different findings in the resolution of different shock states. First, we'll go through hypovolemic shock. Hypovolemic shock is probably the easiest one to think about. It is a sudden reduction of blood volume. As you can see here from the image on the right, there is not enough blood within the body in order to properly perfuse the organs. As a result, we see a decreased preload coming back to the heart as there's not enough blood in the system. We see a decreased cardiac output, again, because there's not enough blood for that heart to pump. We see an increased afterload as the body tries to compensate by increasing its sympathetic tone and increasing systemic vascular resistance. We see a decreased tissue perfusion as there's not enough blood within the system. And the treatment for this is to replace that volume. Typically, that volume that will need to be replaced is what is lost. Typically, it's a patient whom is hemorrhaging and you need to replace with blood. The only thing to replace blood is blood, as other agents do not have oxygen carrying capacity. You can give fluids in patients that have hemorrhagic shock. However, it is only used in small amounts as a crutch until you can get them the blood products that they need. Similarly, with vasopressors, you can use them to augment their blood pressure, but only until you get them the true blood products that are warranted in this situation. The next type of shock we will look at is cardiogenic shock, in which there is a direct insult to the heart muscle itself. Therefore, there's inadequate tissue perfusion due to a primary ventricular failure. As a result, we will see an increased preload as the heart muscle cannot pump what blood it's getting to the rest of the body, and there ends up being a backflow of blood because the heart cannot compensate for the amount that it is receiving. Thus, we see fluid extravasation and edema, similar to those patients that we see with heart failure and lower extremity edema. Similar concept with the cardiogenic shock. We see a decreased cardiac output, again, because that heart muscle has that injury and cannot pump effectively. We see increased afterload as the body tries to compensate by increasing its sympathetic tone and increasing its systemic vascular resistance. And then we see decreased tissue perfusion, again, because that heart muscle cannot pump blood to the rest of the body. Treatments are to restore the pump function. So if you have a myocardial infarction, going in and stenting the area, improving that blood flow to the heart, and hopefully the heart will restore the function that it has and will be able to reverse this cardiogenic shock. Obstructive shock is very similar to cardiogenic shock. The idea, though, being that the heart muscle itself in obstructive shock is not damaged. Therefore, it is something else that is impeding the heart from pumping effectively, whether it be a pericardial tamponade or a pulmonary embolism. As a result, we see many of the same pictures that we would see in cardiogenic shock. We see an increased preload that can lead to venous congestion. We see a decreased cardiac output, again, because that heart cannot pump effectively against whatever that obstruction is. There will be an increased afterload, again, as that sympathetic tone increases. There will be decreased tissue perfusion. And then the treatment is removing the obstruction. So if there is a pericardial tamponade, draining that fluid will help to restore the actual pump function itself, because that heart muscle was never truly injured. It just could not pump against whatever that obstruction was. And the last type of shock that we will talk about is the distributive shock, which does take into consideration the neurogenic, the sepsis, and the anaphylactic shock. It is a true vasodilatory shock, but the biggest one that we will typically see here in the hospital is the septic shock, which is defined as a persistent hypotension, typically as a result of a systemic inflammatory process as it relates to an infection. There will be decreased blood flow to vital organs that will be necessary to monitor. In the early stages of a distributive shock or sepsis picture, we may see a normal to decreased preload, and that's because the body may have adequate stores of blood volume initially, and as your body vasodilates, you can have adequate preload coming back to the heart. But though over time that vasodilation gets much more severe and that preload will decrease, you will have an increased cardiac output as a result of the decreased afterload. And so because there is this systemic vasodilation, even the weakest heart with very poor ejection fraction can pump against something that is not impeding its flow. If there is nothing to resist the function of the heart, then any weak heart can have the best cardiac output. And you may see increased or decreased tissue perfusion. As you have this systemic vasodilation, you may see an increase in tissue perfusion as a result of blood getting to all of the tissues, but then as a result of that systemic vasodilation over time, and inflammatory markers increasing and capillary leak worsening, we then start to see that decreased tissue perfusion, which leads to poor outcomes. The treatment for this type of shock is, of course, source control. And so if we can mitigate the agent that is causing the issue, that's the first step in this process towards treating these patients. Further from that, we'd like to, of course, do our hemodynamic control until that source control can be reversed. Hemodynamic control can be through the use of fluids, similarly in sepsis, where we do our 30 mLs per kilo, and then followed by vasopressors as we need them. Now, I'd like to take a minute to discuss some of the hemodynamics that we look at in states of shock, one of the biggest being mean arterial pressure, or the MAP. We see here the equation of systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. Basically, it is just an average of the total amount of time that you are in systole and diastole. Therefore, diastole is multiplied by 2 because we are in diastole 2 times longer than we are in systole, and it then is an average of those blood pressures. Now, if you were to look at your monitors in the units, you will find that the MAP calculation that you see here does not correlate with the numbers that you will see on the screens, and that's because the monitors that we are using in the hospital are much more sophisticated and take into consideration numerous other variables as a result, and the MAP number will not equal exactly based on this equation. Next things that we think about in terms of hemodynamics is stroke volume, which is important because this is affected by the different states of shock. So we have our preload, which is the amount of blood that's coming into the heart. We have the intrinsic contractility, how well that heart is actually functioning. And then we have the afterload, which is the pressure at which the heart has to pump against, or that systemic vascular resistance. We look at cardiac output, which takes into consideration that stroke volume and multiplies that by the heart rate. And then we look at systemic vascular resistance, which increases with constriction and decreases with vasodilation, which makes sense, but you have to take into consideration the type of shock and then the other therapies that we'll be putting on board and what they will do to the systemic vascular resistance. Now, it's important to keep all of these numbers and hemodynamic measures in mind, but the biggest thing that we want to take into consideration are the patient goals that we're looking for. So yes, we are trying to achieve specific MAPs and systolic blood pressures, but we really want to be focusing on the patient's mental status. How is their mentation improving? Their urine output, their capillary refill. Are we getting these patients to perfusing their end organs? How is their lung function? Or how are their oxygen requirements? Are their ventilation requirements decreasing? So these are all things that we want to make sure that we keep in mind for the patient, and not necessarily just the numbers that we'll be looking at when we see these goals that we're shooting for. So now we'll get into the types of vasopressors that there are. In order to be defined as a vasopressor, typically we think of something that increases systemic vascular resistance and puts squeeze on the actual blood vessels themselves. So we think of epinephrine, norepinephrine, phenylephrine, dopamine, and vasopressin. I have an asterisk next to vasopressin because the first four, epinephrine, norepinephrine, phenylephrine, and dopamine, all have some level of alpha-1 activity, which we will talk about in a minute, but that is what's the focusing point of increasing blood pressure. But vasopressin does not have that alpha property associated with it. So it will increase blood pressure and peripheral squeeze on the vasculature, but it is not through that alpha activity. When we look at the different receptors that we're worried about when we think about vasopressors, we think of the first one being that alpha-1 property, typically being that's the property associated with a true vasopressor that will increase blood pressure. So it does mediate our peripheral vascular resistance. Alpha-2 is a feedback inhibition of sympathetic transmission. And so if you have an agent such as clonidine, which is an alpha-2 agonist, then you will see that as your body utilizes the clonidine, it thinks it's getting enough of a sympathetic tone. As a result, it does not release as much catecholamines, and your blood vessels actually vasodilate. Beta-1 is the heart-specific beta receptor that does increase inotropy or force and chronotopy or rate. It does also increase cardiac output, increases myocardial oxygen demand, and increases systolic blood pressure. The beta-2 function actually has a decrease in peripheral resistance and a decrease in diastolic blood pressure. Now, this is important, especially when you have true beta agonists like dobutamine. You may see an increase in force and chronotropy or rate with the beta-1 function, but you also may see a subsequent small drop in blood pressure with that beta-2 properties. Now, dobutamine is not one that we will be discussing today, but keep in mind that those properties are there. And then lastly, we have the D1 receptor or the dopamine receptor, which will come into play when we talk about dopamine as a vasopressor, and that is aims to vasodilate vascular smooth muscle cells. Now, this is a full chart on all of the receptor pharmacology for each one of the catechol-based vasopressors that we're going to be talking about. Now, I will go through this chart with one by one, talking about each specific medication. But in the interim, we can see that we're going to be talking about the dopamine receptor, the beta-1 receptor, the beta-2 receptor, alpha-1 receptor, alpha-2 receptor, and then the specific medications' effects on heart rate, MAP, systemic vascular resistance, and MVO2, which is the mixed venous oxygen saturation, which is basically a measure of perfusion to the tissues. The first vasopressor that we'll talk about is norepinephrine. Now, this agent was classically defined as Levophed, Levomdead, and that's as a result of the brand name Levophed, norepinephrine, and the fact that when you had to use this agent in a patient, you knew that you were already on a last-ditch effort to try and save this patient, and they were already better off just passing away rather than trying to go through the potential side effects of this medication. But it has since come a long way, and it has now really become our first and primary agent of choice in nearly all situations where we need to augment blood pressure. If you did not have any idea what type of shock this patient was in, and you just needed to know that you needed to raise their blood pressure, and you chose norepinephrine 9 times out of 10, you would be correct. And the other 1 out of 10 time, you would probably not be wrong. Norepinephrine has a good middle-of-the-road property associated with its alpha properties, its beta properties, and its effect on the heart rate, mean arterial pressure, systemic vascular resistance, and mixed venous oxygen saturation. So it does have that alpha property to augment the blood pressure that we want, and it also has some beta properties. Though it does not have significant amounts of beta properties, it will still give you some of that augmented heart rate that you'd like to see. It is a potent alpha agonist. It will increase the MAP. It will have less effects on the heart rate at lower doses, though for the most part what we will be seeing is you will see some beta activity. So even though the lower doses do exist, for the most part you can expect that there will be some beta-1 activity. And now it improves renal blood flow in fluid resuscitated patients, and that's an important key concept to take into consideration is fluid resuscitated patients. Now, if you were to place some of these agents on patients who aren't properly fluid resuscitated or do not have enough volume in their body, and you give them a vasopressor, this is where you start to see those deleterious effects of blue fingers and severe cyanosis and necrotic tissue, because you're then clamping down in areas of small vasculature that don't have enough fluid in them. So if you do properly resuscitate these patients and you know where their status is before you start adding these agents on, you truly can have excellent outcomes in these patients. It is useful in septic shock. It is actually the #1 agent of choice. It is our preferred agent first line. And it's also a good agent to use in just standard vasodilatory shock in general. Adverse drug reaction include, of course, significant vasoconstriction, which makes sense with it being a vasopressor. Another specific adverse drug reaction is arrhythmias. Now, there are other vasopressors out there that may be more arrhythmogenic, but this is one to take into consideration that you may have a patient that does experience new onset arrhythmias while they're on norepinephrine. When you see the order come through for norepinephrine, you will see it says it's to titrate to a MAP or systolic blood pressure goal. Typically that MAP goal will be 65 or that systolic blood pressure goal will be 90. Now these goals are set because those are typically the goals that we think of where we will have enough end organ perfusion to our vital organs like our kidneys and our brain to make sure that they're functioning appropriately. Now these are important to take into consideration because it is also still patient specific, even though we do have those numbers. Now you'll start at 0.6 to 10 mics per kilo per minute or continuing at the current infusion rate. Now that is our starting dose, and then there is a range within that starting dose. So you really have to take into consideration the clinical status of the patient. Is this a patient whom is crashing on you that needs blood pressure control immediately? You're probably going to want to start at that high end, 5 to 10 mics per kilo per minute, and titrate from there, rather than starting at 0.6 mics per kilo, or mics per minute, and then titrating upwards from there. So really evaluating what the status of the patient is while you're placing these medications on board. We're going to titrate by 0.5 to 5 mics per minute every 1 to 2 minutes. Now again, keeping in consideration where you are in that dosage range. As you can see here at the bottom, the order range is between 0.6 and 30 mics per kilo per minute with a usual max of 80 mics per kilo per minute. If you're up in these higher ranges of 50 to 80, you may not want to titrate by 0.5 mics per minute. You may want to do that higher end of 5 mics per minute. But again, if you have a patient who's now coming off of or being just started on norepinephrine and you're at the low ranges between 2 and 5, titrating by 0.5 mics per minute makes more sense. If you titrate too much, so more than 20 mics per minute within 30 minutes, you will contact the provider. The standard concentration that we have here is 16 milligrams per 250. You can also increase the concentration to 32 milligrams per 250 mLs. You will typically increase in concentration if you have a patient whom is very volume sensitive. If they are on a fluid restricted therapy, then you can consider increasing the concentration if they're going to be on high doses of these vasopressors. Now, the order range as it comes through, the default is this 0.6 to 30 mics per minute. But again, the usual max is 80. So if you do have a patient that's going to require more than 30 mics per minute, you will have to contact the provider to place a new order to extend that range to the higher range of 0.6 to 80 potentially. So keeping that in mind and having those discussions with the providers. The next vasopressor that we'll talk about is epinephrine. Now, epinephrine does have some dose-dependent properties on which receptors it will actually hit. So I put the dose-dependent properties up here. They're the low and higher dose epinephrines of 0.01 to 0.05 mics per kilo per minute and greater than 0.05 mics per kilo per minute. Now, keep in mind here that this is dose-dependent in mics per kilo per minute. Though here we do not dose based on mics per kilo per minute. We do dose our epinephrine based on mics per minute. So we typically will not see the dose-dependent properties in this first line here with the 0.01 to 0.05 mics per kilo per minute. With most of the doses that we will be seeing in our patients, we will probably be seeing more of what's going on in the second line here. But I did want to include this just to keep you guys aware. If you do have somebody on a very low dose of epinephrine, you may see some different properties associated with it. Now, epinephrine will increase MAP in septic shock secondary to an increased stroke volume and heart rate. It does have more potent effect on contractility than norepinephrine, so it does increase heart rate more, and that's largely due to its beta-1 properties. So it does have more beta activity than the norepinephrine counterpart, but it does still have some significant alpha-1 properties. Now, epinephrine's mainstay of therapy is useful in cardiopulmonary resuscitation and anaphylaxis. Now, even though these two indications are dosed very differently with milligram for cardiopulmonary resuscitation and our 0.5 milligram IM injection for our anaphylaxis dosing, these are, it's important to take into consideration because if you do have a patient who maybe is a candidate whom you are performing CPR on and have gone through 3 rounds of epinephrine and now you've achieved ROSC, they now have 3 milligrams of epinephrine coursing through their veins, and you're going to need potentially something to now augment that therapy once the epinephrine starts wearing off. And so an epinephrine drip may be a reasonable medication to think about in that case so that you can maintain that vascular tone that you want in post cardiopulmonary resuscitation care. Now, it is a secondary drug of choice in sepsis, but it may not be the secondary drug of choice in sepsis. When you look at the guidelines, it does say norepinephrine is our first-line agent, or you can consider vasopressin or epinephrine. Now, we are an institution that does prefer vasopressin before epinephrine, but it is not uncommon to see an epinephrine drip in select patients potentially before vasopressin. Adverse drug reactions include decreasing splanchnic blood flow, increasing myocardial workflow. It may decrease potassium and phosphate, but typically it's not significant enough as to where you need to be too concerned, but notice that it may happen. Hyperglycemia, tachycardia, and then a big one here is that it may not allow lactate clearance. Now, this is important, especially for our sepsis patients in whom we may be trying to monitor their lactate clearance because it may be a function of how well we are resuscitating this patient. And if you have a patient who is on epinephrine, you will find that they will not clear their lactate as well. And that's largely as a result of the epinephrine's significant beta properties associated with it, specifically that beta 2 property. When you see this order come through, again, you'll see it titrating to a MAP or systolic blood pressure goal, very similar to norepinephrine, where we're going to start at a low range between 0.5 0.5 and 5 mics per minute, titrating by 0.5 to 2 mics per minute every 1 to 2 minutes, and again, contacting the provider if you adjusted more than 20 and 30 minutes. The concentrations that we see here are 4 per 250 and 16 per 250. The default is the 4 per 250. The order range that you'll see, there's 2 specific buttons that you can choose in the order of 0.5 to 10 mics per minute or 0.5 to 30 mics per minute. But again, same thing here with norepinephrine is the usual max is 80. So again, if you have these patients that are going to be on higher doses or require higher than that order range, you will need to get another order to go higher than that range. And just recognizing that even if you're at the high end of that range at 30 mics per minute, you may be able to go higher, especially if the patient needs it. You just have to ask for that order. Phenylephrine is the next vasopressor that we'll discuss. Phenylephrine is unique because it's a pure alpha agonist. It does not have any effects on heart rate, directly at least. It's not recommended in septic shock unless the norepinephrine that you're using, again, that first line agent, produces significant arrhythmias. Or you can consider it in when patients have a cardiac output that's high, but their blood pressure remains low, where you don't need any function on the heart itself, but you do need to augment blood pressure a little bit. Or you can use it as salvage therapy, where the patient's already on 3-4 pressors, and you need to add another agent to continue therapy for this patient. Now, it is interestingly the agent of choice in patients with aortic stenosis. This does not seem very intuitive because why would you give a patient a pure alpha squeezing agent in a patient that already has an aorta that is stenosed? However, in this situation, it's beneficial because as the alpha property exhibits its peripheral vascular resistance, it really has no effects on that stenosed aorta, but it will augment blood pressure, and then it potentially will have a rebound effect of a reflex bradycardia, which will then be of benefit in a patient with a disease such as aortic stenosis. Adverse drug reactions include severe vasoconstriction, a reflex bradycardia, which again may be beneficial in those patients with aortic stenosis, and cardiac ischemia. Now, we'll typically see this agent used again in that aortic stenosis population, or potentially as an agent to help augment peri-procedural blood pressure. So if a patient needs to be intubated, you may use a phenylephrine stick or a neo stick, which is a syringe of phenylephrine where you can push in small increments in order to augment blood pressure in the peri-procedural area. As you see this order come through, again, titrating to that MAP or systolic blood pressure goal. The doses here that we see are much higher. So we're going to start at 25 to 100 mics per minute, and then we're going to titrate by 10 to 50 mics per minute. Now, this is every 5 to 10 minutes comparatively to the norepinephrine and epinephrine at 1 to 2 minutes. So then again, contacting the physician if it is adjusted by more than 200 mics per minute in 30 minutes. There are 3 concentrations within the order, so there's 10 milligrams per 250, 80 per 250, which is the default, or there's 160 milligrams per 250. The order range that we see is 25 to 300. Again, usual max being higher at 500 mics per minute, so you will have to get another order should you go beyond that 300 mics per minute. Now, the next vasopressor we're talking about was dopamine. Now, dopamine is very important to discuss because of its dose-dependent pharmacology. So you'll see here in the chart we have a dopamine of less than 3 mics per kilo per minute, which is quoted as the low-dose dopamine or renal dose dopamine. We have dopamine at 3 to 10 mics per kilo per minute and dopamine at 10 to 20 mics per kilo per minute. Now, depending on the literature that you look at and the different sources that are out there, you may see that low dose or renal dose dopamine being less than 3 mics per kilo per minute, or you may see it say less than 5 mics per kilo per minute. And then the middle dose dopamine may be 3 to 10, it may be 5 to 10, it may be 3 to 8. There is variance within the literature of where those cutoffs are, but the important thing to recognize is that there is specific dose-dependent properties associated with each. Now, this is a medication that we do dose in mics per kilo per minute here at the Cleveland Clinic. So you will potentially see some of these specific properties associated with each dosage range. Now, the low dose, or quote unquote renal dose dopamine, is a result of the vasodilation of the renal, mesenteric, and coronary arteries. It has been dubbed the renal dose dopamine because it had been said to augment blood flow to the kidneys and therefore potentially increasing perfusion to the kidneys and having beneficial outcomes, though this has largely been studied and found to not be the case. There are no good outcomes associated with using low dose or renal dose dopamine. As a result, it has largely fallen out of favor, and you will not see orders typically come through for low dose or renal dose dopamine. Now, it has those effects because it specifically only hits on that dopamine receptor, that D1 receptor that has that vasodilation properties. Now, as you move up in dose, you get to the medium dose dopamine, which specifically is our beta properties. So you will see increased contractility of the heart and increasing heart rate. So this is where you have all of your beta 1 function, where it's your pure inotropic agent for potentially heart failure patients. And then as you move higher in that dose range, you move through beta and you get to your alpha properties, where you have that arterial vasoconstriction. Now, it's important to note these differences in ranges because you need to know what type of properties that you're looking for in this agent to be able to appropriately manage the patient at hand. So if you have a patient whom is crashing, that their blood pressure is significantly lower, you're going to need to be on the high end of dopamine between that 10 to 20 to have those effects on blood pressure that you want. Otherwise, you will only get that beta property associated with it. The maximum effect does appear to be at 20 mics per kilo per minute, though, so going beyond that does not seem to have any benefit or any increase in therapy or efficacy. It is most effective for patients whom are hypotensive, that have a depressed cardiac function or cardiac reserves, those patients that are in vasodilatory shock with a subsequent bradycardia. And that's because you can use this agent for its beta and alpha properties. Again, you have to go through beta in order to get to alpha. You can also utilize this when you have a patient whom is at low risk for arrhythmias, though that may be difficult to determine, especially if the patient does not have a history of arrhythmias. And even if they don't have a history of arrhythmias, it may be difficult to assess risk as you are putting them on an agent that will be pro-arrhythmogenic. It may also be useful in patients, though, that do have significant bradycardia because of those significant beta properties that you will see. Adverse drug reactions include tachycardia, arrhythmogenesis, and peripheral vasoconstriction. Now, when you see this order come through, again, same thing, titrating to a MAP or systolic blood pressure goal. However, it's really important to notice the titration ranges and the starting doses for each one of these and associating those with the properties of dopamine. So we start our infusions at 2.5 to 5 mics per kilo per minute or continuing at the current infusion rate. But again, that 2.5 to 5, you may be falling within that range between renal dose dopamine and the beta properties of dopamine, where you have the inotropic effects. And so if you start at 2.5, you may be within the range of the renal dose dopamine. If you go up to 5, you may be at the inotropic effects, or you may still be in the low dose dopamine range, because some of the literature out there does say that you can go up to 5 for just having low dose dopamine properties without having inotropic effects. So you really have to take into consideration what your patient needs and monitoring them appropriately. Same thing when you're titrating this medication. So titrating by 2 to 5 mics per kilo per minute every 5 to 10 minutes. But again, as you titrate this medication, you'll be going through each one of those specific ranges from your renal dose to middle dose dopamine, middle dose to high dose dopamine, and you'll be seeing drastic effects as you titrate between each one of them. So if you want to use only the beta inotropic effects of dopamine and you want to titrate, be careful not to titrate too high where you'll get some more of the alpha associated properties and increase their blood pressure when you did not want to and you only wanted the inotropic effects of dopamine. Again, contact the physician if you do adjust the dose by more than 20 within 30 minutes. And then the concentration is standard at 800 per 250. And the order range that you will see is 2.5 mics per kilo per minute to 20 mics per kilo per minute. Now, keep in mind the order range is only to that 20. You will likely not see a benefit of higher than 20, so we likely will not have higher doses. But again, keep in mind, though, that it does say contact the physician if the dose is adjusted by more than 20. Well, when our range is ordered 2.5 to 20, keep in mind your clinical judgment, where if they are increasing a lot, you may want to contact the provider before you have such large titrations in this medication, especially given the properties that are associated with dopamine. The last vasopressor that we'll talk about is vasopressin, or antidiuretic hormone. It is not a catecholamine, but it does have its effects on the vasculature, which is why it's still a vasopressor. It is released in response to a decreased blood volume or an increased plasma osmolarity. Again, it is a natural endogenous hormone. So as you have that decreased blood volume, you'll see that V1 receptor being acted on and will constrict smooth muscle and indirectly release catechols in order to respond appropriately to that decreased blood volume. If your body senses an increase in plasma osmolarity, that's where you'll see that V2 receptor activity, and you'll actually have the true antidiuretic hormone activity to hold on to some of that water. Now, in septic shock, it's noticed that there is a relative deficiency of vasopressin. So you will see this low-dose vasopressin of 0.01 to 0.04 units will increase your mean arterial pressure in catechol-resistant hypotension. And the sepsis dose that we use for repleting this vasopressin is 0.03 units per minute. Now, this is a dose that will only replete the vasopressin that you are deficient in septic shock. If you were to give this dose in a normal individual whom has adequate supplies of vasopressin or ADH, there likely will not be really any effects that you will see utilizing this dose, because they have enough endogenous supply of an antidiuretic hormone already. This is specifically a dose utilized to restore what is lost in a patient that has septic shock. Now, when you do initiate this, you will potentially see that the concurrent vasopressor that you're using, typically it's going to be norepinephrine, that dose may be reduced as you add on that agent, and you will able to restore their vasopressin stores, and they increase in MAP due to the catechol resistance. You'll be able to see you can come down a little bit on the norepinephrine dose. Adverse drug reactions include myocardial ischemia, necrotic skin lesions, and bowel ischemia. Now, these are typically more associated with, again, those higher doses than the 0.03, because that 0.03 is really just the replacement dose. It's doses where you get to 0.06, 0.1, even as high as 0.2 in some literature, where you start seeing these really nasty side effects, or for very prolonged infusions. Now, when you see this order come through, you'll see it come through as a constant rate, so it is not a titratable vasopressor, and it will be in a concentration of 20 units per 100 mLs or 60 units per 100 mLs. And the order range will be 0.03 units per minute or 0.04 units per minute, again, a constant rate. Now, when you're ordering, you want to make sure that you're asking for what the starting dose should be. There are ranges between what that starting dose should be. So how's the patient looking? Are they currently stable and just need some augmented blood pressure support, or are they unstable and they're crashing on you and you do need to start at those higher doses? The titration parameters, by how much and how often. Do you have a crashing patient whom you start on the high end and need to increase by the high end of the range of titration parameters more often? Or are you perhaps coming down on these vasopressors and can titrate a little bit differently? And then what the titration goals are. So to what end are we actually titrating these medications to? We have these goals of a MAP of 65 and a systolic blood pressure of 90, but really taking into consideration what's the clinical status of the patient. Is the patient at a MAP of 65, but their urine output has not increased at all, and a patient that did not normally have reduced kidney function? You have to make make sure you're monitoring these patients appropriately. And maybe a MAP of 65 for this patient was not appropriate and they need a higher MAP goal. And maybe this was a patient that had chronic hypertension that was uncontrolled and they lived at a higher blood pressure, and therefore their MAPs to perfuse their kidneys are actually higher than the 65 that we're shooting for. So really monitoring your patients and seeing what are you actually trying to achieve when you're assessing these patients and utilizing these medications. For a general titration, just all in one slide, I have norepinephrine and epinephrine. We're titrating every 1 to 2 minutes. Phenylephrine every 10 minutes. Dopamine every 5 minutes. And vasopressin, again, is typically non-titratable. Now, when you are titrating, again, really don't forget to titrate down on these vasopressors. It's important that we do reach these goals and MAP goals and patient outcomes that we're looking for, urine output, mental status. But as we achieve those goals, start to think about when can you back down on these vasopressors. Have you met this goal over a sufficient enough time where you can start to back down now on your vasopressors and titrate back down to see if the patient is now maintaining the vascular tone that they need, the perfusion that they need. Because the longer that these patients are on vasopressor therapy, we will be starting to increase their ICU stay, increasing their hospital stay, and then of course we're going to be increasing the incidence of side effects as these patients are on prolonged therapy. As these side effects are important to consider, extravasation is one that we need to always keep in the back of our mind. Now, there are risk factors associated with patients who are more likely at risk to develop extravasation, and that's for patients who are getting vasopressors at a rapid rate with a high volume concentration drug. A prolonged or peripheral administration of these vasopressors can lead to extravasation. Now, central lines are preferred in patients whom are utilizing vasopressors, though peripheral lines can be utilized safely for short periods of time in veins that are good solid veins that flush appropriately, and that they can be safely utilized in patients. But you really do want to try to avoid veins that are injured, sclerosed, small, fragile, or located in areas of flexion so that the patient can't move around and displace the IV line and then thus cause extravasation. So you really have to take these into consideration. But again, just because a central line is preferred, take into consideration the status of the patient. If they're crashing on you and you only have a peripheral line and getting a central line will be detrimental to the patient, start these vasopressors early in these patients to get their pressures under control and then evaluate central lines from there. Now, if extravasation does occur with norepinephrine, epinephrine, dopamine, or phenylephrine, we can use phentolamine or nitroglycerin ointment. If we use vasopressin and extravasates, we can use nitroglycerin ointment only. Now, the reason for that is because phentolamine is an alpha antagonist, and so those previous drugs all had alpha properties associated with it, whereas the vasopressin does not have any alpha properties associated with it. Therefore, you need a true vasodilating agent. With phentolamine, you're going to want to infiltrate the extravasation site with 5 to 10 milligrams of drug, diluted in 10 to 20 mLs of normal saline, as soon as possible as after extravasation for best effects, though you can still do it within 12 hours, and you can readminister if the patient remains symptomatic. Now, the nitroglycerin ointment is a true vasodilator, so you will apply a 1-inch strip to the site of ischemia every 8 hours as needed, but because this is formulated as a medication to be absorbed very well through the skin, you do need to monitor for systemic hypotension that can result. Other considerations for patients who do extravasate are applying heat proximal to the site of extravasation. You can elevate the site of extravasation, or if there's any drug shortage for whatever reason, we can't get phentolamine, we can't get nitroglycerin, you can consider the use of 1 milligram of terbutaline in 10 mLs of normal saline, because terbutaline is a beta-2 agonist, which will dilate blood vessels, and you can inject this locally across the symptomatic sites. Now, most of you will probably forget these extravasation things that you can use, and so if you look on your MAR, there will be a site under each one of these vasopressors for the extravasation policies. You can click on that. It will take you to a screen where it shows what medications to use if the medication does extravasate. Lastly, I wanted to bring up this flowchart that we have for vasoactive medication titration in septic shock, because this is the most common indication for utilizing these vasopressors that you'll be using. So with septic shock, norepinephrine is our first line agent. We can see as we go down this chart, we start our norepinephrine and try to achieve that MAP goal. If we don't achieve that MAP goal, we can increase up to around 50 mics per minute of norepinephrine. Once you reach 50 mics per minute of norepinephrine and have not reached that MAP goal, you can then add on 0.03 units per minute without titrating of vasopressor. Then you can continue to titrate up that norepinephrine goal to the max 80 mics per minute. If you've yet to achieve the MAP goal, then you can then ask for epinephrine to be added. So you need a titratable dose for epinephrine. You request the order for the norepinephrine to be non-titratable and leave it at that max goal. And then you can titrate the epinephrine from there. Now, should the patient experience multiple arrhythmias on the norepinephrine, you can ask the physician for phenylephrine in place of the norepinephrine and titrate accordingly with the phenylephrine and following the same process. Now, just as important it is to initiate, it's as important to discontinue. As a rule of thumb, the first medication on is the last medication to be titrated off. So here we are starting with norepinephrine, and our last medication to come off is norepinephrine. Now, as we're discontinuing, we're titrating off of the norepinephrine down to 0. Once the epinephrine is titrated down to 0, then you can request an order for norepinephrine to be titratable. You can then titrate the norepinephrine down to that less than 40 mics per minute. Once the norepinephrine has been titrated down to less than 40, then you can let the bag of the vasopressin run out. Then you can continue titrating down on your norepinephrine. And norepinephrine will be the last one that you do stop in the patient. So in summary, vasopressors are used to help support hemodynamic status of crashing patients in states of shock. Each vasopressor has unique nuances that should be taken into consideration when choosing these agents, and to monitor the effects of these vasopressors based on the status of the patient, really looking at the clinical picture. How's their mental status doing? How's their urine output doing? How are their oxygenation requirements? What's their cap refill look like? Really evaluating these patients and making sure that we're utilizing these vasopressors in the appropriate setting for the appropriate patients, and then also coming off of these vasopressors as we can, because we do not want these patients to be on prolonged uses of these medications. Thank you. That is the end of the presentation.